So this is what we call exam 3 of pediatric nursing. I know that exam 3 is tricky. You have to really read the questions carefully, okay? I always say that, but know that it's so true that there's some that um, they're very similar. And as we get there, I will let you know. So there are a lot of chapters, I know, but let's start with the information and concepts. So, head injuries. Head injuries in children are common, aren't they? It's they fall down and they go boom. And the problem is, it's motor vehicles is always your number one accident place. We know that. And of course, bicycles, sports, etc. And know that head injuries in children create um, scenarios, and some of them can go even where they go unconscious. So, as you are taking care of that child with that head injury, you're going to monitor for a change in consciousness. All right. So, it could be they're awake and alert, and then all of a sudden they're starting to ask you, so was I safe if they're sliding into third base? Or where's my daddy? They're coming. And we've told them 10 times already. That's the change in their level of consciousness, just that orientation. Other signs, if the child vomits more than 3 times, so increasing vomiting, increasing change of level of consciousness, double blurred vision, diplopia, right? Or trouble walking, and a headache that becomes more severe and wakes them up at night. That's telling you a head injury is getting worse. That's what you need to tell that child, and that the child's parents, so they can monitor them. Also know that older kids that get head injuries like concussions, we have to be aware that they've had some sort of mental, moment that they shouldn't be driving until they're cleared by a doctor, because they could still have that concussion and they're not thinking correctly. So, observation, what are you going to think to monitor? As I said, the change or worsening level of consciousness, or they're acting weird, strange, they're doing things that, what are they doing? If they're restless, difficult to arouse, vomiting more than 3 times, pupillary changes, and it is said if you have a fixed, dilated pupil, it is a neurological emergency. And what is that telling you? There's a lot of swelling going on in the brain stem. It's squeezing the brain. And now you're going to have permanent brain damage if we don't have neurosurgery, evacuate the hematoma or whatever's going on. Okay, that's what that pupil fixed means. It's the first thing as a nurse that we get kids who've fallen off of second floor balconies and stuff. First thing we look at is look at their pupils. Are they already blown, or are they reactive? Are you have a child? Do you need to get to the OR quick, or can we treat them here in the ER? And that actually is your determining factor. It's pupils. Again, it could be double blurred vision. Again, that trouble walking is because of the pressure in the brain. Your muscles, the nerves are not working. It's all disconnect going on. And the other one is headache that's becoming more and more severe and wakes them up at night. Wakes them up from a sleep. That's a bad headache. Now, a traumatic brain injury. Now, I've put like the absolute, you know, most big head to show you. Those are distended neck scalp veins. Usually it's the one right by the ear, and it'll pop out, and it's actually an artery, and it will start to throb. You see it. Now, fontanelles in children tell you many things. And this exam does a lot of them. But on a child who's having increasing head injury, increasing pressure going on, that fontanelle is going to start to bulge, right? We also see fontanelles in children where they sink, and that's all about dehydration. So fontanelles, infants, always you're going to check. Now, why do you think they're bradycardic? Again, pressure pushing on that brain stem, telling that heart rate center it doesn't know what to do now, so it just starts to slow down. Okay. Now, meningitis. Child comes in with all the symptoms, the photophobia, the headache, the neck stiffness, etc. number one thing that you need to plan on is a lumbar puncture. Now, all meningitis is not bacterial. We have viral and we have bacterial, just like we have viral pneumonia, bacterial pneumonia. So viruses don't get antibiotics. Remember that, okay? Meningitis is something that you need airflow going on in your room. These children diagnosed after doing a lumbar puncture, we say that they're a bacterial meningitis. These children must be placed on an isolation, and it's all airborne, okay? What they say is after one day, though, you can take them off if they've started their antibiotics. So what do you see in that cerebral spinal fluid? Well, we're going to see increased protein because bacteria don't like protein. It goes yuck. But they love sugar, so glucose is low. Also, your fluid is going to be cloudy, and that's white blood cells. It looks milky. That's all bacterial. That's what you see. In a viral lumbar puncture, it's going to be clear liquid. So you really know that what it is even before it goes up to the lab. With any time we enter the spinal column, whether it's spinal anesthesia, whether it's lumbar punctures, make sure that they lie flat for at least 30 minutes. Spinal headaches are horrible. The other thing is fluids. Give them fluids, whether IV, PO, because that helps get rid of, gets that volume back into the cerebral spinal fluid in the body, and that does help. So what do? We figure out bacterial meningitis, right? So we're going to need IV fluids for IV antibiotics. Some of the children can eat. Their headache is so bad. Some of them don't. So whether you feed them or not doesn't matter. It just depends on the child. So these children will be placed in a isolation room for droplets, okay? Because that's the way the isolation that it is. Our priority on this child is antibiotics if it's bacterial. Okay, makes sense, doesn't it? You got to kill that bacteria quick. And the other thing is their heads hurt. So no lights, minimal stimulation, no noise. These children, when they're placed in this isolation, are in usually a private room so that you can pull curtains and everything and make it really, really quiet. Now, one of the things with increased intracranial pressure with the meningitis, know that sometimes the pressure gets so much, they call it cerebral edema, that we need to monitor for that. And cerebral edema, again, is increasing intracranial pressure, increasing in symptoms, and that's what we'd be looking for. So, cerebral edema, it's swollen in there. What are you going to do? It's too much pressure, too much fluid. Let's get rid of it. Let's give a diuretic. But the diuretic is not your normal one. It's the one for the head, mannitol. Okay? Furosemide is lungs all filled up, peripheral filled up, but specifically for the brain, mannitol. So again, monitoring long-term in the bed, ICU patient, and with a head problem, always monitor intake output. No, you do not want to overload that child because you're going to cause cerebral edema if you too much that we're putting into the child. So again, what are we going to see? They're very, very similar head injuries, right? Monitor change in level of consciousness. They're going to be lethargic. They're going to have that headache. They're going to be vomiting. And those fontanelles are going to be big. And, because they don't have any energy at all, again, the infant's going to be lethargic too. Now, one of the things that can occur with hydrocephalus, fluid in the brain, we have to get rid of it. And that fluid in the brain, again, is like a head injury. It's pushing. It's just absolutely causing the head to get bigger. There's another thing that's called a Mason's sign, and it is a sign to detect hydrocephalus. You can tap on the head and you can hear it. Believe it or not, the neurosurgeon will do this thing. Is it abscess or is it water? There's a different sound that you do hear, believe it or not. And then I found finally a sun setting eyes. There they are. Their suns are setting. and that sunset eyes, and of course, vomiting, headache, all of those good things. So with that VP shunt, we're going to put it up into the fourth ventricle. There's a picture of it, what it looks like behind the ear. There's like a lump there. And actually, there's a place where you can pump, but you will never, ever, ever, ever touch that. This is only for the neurosurgeon. So, what is our responsibility? We have a big head full of fluid. We've inserted a tube. Well, we're going to monitor head circumference. Is it working? Is it getting smaller? Right? Very important to look at that. Also, children, increased intracranial pressure. We have these kids, a lot of times sedated and whatnot. And you're going to say, well, how can you figure out a sedated child? How do they have pain? And believe it or not, even a sedated, paralyzed child in pain is going to have an elevated heart rate and elevated blood pressure. And you could watch it and you're like, what's going on? So you give a little extra pain medicine and then you watch the numbers come down. Now, neuroblastoma is a brain. Nephroblastoma is a kidney. Okay. The thing with the difference is Wilms tumor is called a nephroblastoma. And anything with kidneys, you always worry about blood pressures. And if this kidney is spewing out some catecholamines, sympathetic type of enzymes, it's going to elevate the blood pressure. It's going to elevate the heart rate. And we're going to treat that with medications like enalapril, one of the prills. And that's one that works very, very well. Vasotec and enalapril, it's the same name. Now, a neuroblastoma is the same thing. So what do you see overall with taking care of these children? We're worried about vital signs. There's nothing we can do as in treatment, but we can monitor what the child is showing us with these. So monitor the vital signs, especially the blood pressure. And as I said, elevated blood pressure in children, enalapril, Vasotec is the same name. We use it in adults, but again, it's given milligrams per kilogram per dose. And I've seen infants on it and it works well. Okay, seizures. Well, a lot of things can cause seizures. I think the number one should be on the top, febrile seizures, right? Know that febrile seizures is something that from about 6 months to 6 years, and it's because the temperature was normal, and all of a sudden, 20 minutes later, it's 102. So it's the rate of rise says to the head, uh-oh, and disconnect happens, and you have a seizure because it doesn't know how to handle this sudden increase in temperature. And that's why they seize. As they get older, the body gets used to it. So they don't have those, febrile seizures anymore. Now, other seizures, just, what causes them? Overwhelming infections, lesions, hemorrhage in the brain. There are metabolic disorders, Tay-Sachs and the fats, and accumulating and clogging off areas up in the brain. Trauma, of course. I mean, I've seen car accidents, head injuries, falling off of all different things, handlebars, second stories, horses. I could go on and on. Children fall down all the time onto their heads. Children can be born with brain malformations. It could be genetic, and it could be they something. It could be a plant, could be a medicine, toxic, something into them. So in children, we used to have grand mal and we used to have petit mal, but they don't use those anymore. So when we talk about that generalized grand mal type thing, we're talking tonic-clonic. That means arms and legs and foaming at the mouth, what you see. So they go flexion, extension, violently shaking. They do have a postictal sort of, I don't know what went on here, which means a level of consciousness is going to be decreased, and that foaming at the mouth. Now, those petite mals could be something as simple as a little partial thing. Could be a quiver of a lip, quiver of an arm, could be one finger, it could be, but very minimal. It's hard to see. times you're looking at a child and they blank, and that could be that type of seizure. So, child is having a seizure. You walk into the room. What is your responsibility? Well, when they're having a seizure, nothing in their mouth. Okay? What we do is we put the bed down, side rails up, we take out the pillow, we put them on their side, and we have suction at the bedside. Children love to have toys and all sorts of things in their bed. I take them and I just work them off to the and over the end of the bed so that we can still work on the child. Because it could be cards, could be pencils, pens, and they could really harm themselves on it. So get that out of there. And then, of course, your suction should be there, not to put in their mouth, to just suction the area around if they vomit so that when they're turned, they're not sucking in vomit. Okay. And then, of course, there are seizures that go on and on called status epilepticus. Okay. And these go on and on no matter what you do. So you need to give some medications. Lorazepam, number one drug. Ativan, Valium, those are your number one drugs that you will be given to try to stop them. So your priority for seizures is safety. The other priority is to teach your parents to be safe, as in, don't let your child in the middle of a lake by themselves swimming because they could have a seizure in the middle of the lake when they're by themselves. So you have to be aware of these things. The
Ms.
pituitary
Bogart,
gland. Yes,
excuse me. What did you say the medications were for seizures?
it could be lorazepam, which is Ativan, diazepam, which is Valium. Those are the first two benzodiazepines that we would be
Mm-hmm.
using.
Okay.
Okay. So
Yes, ma'am.
pituitary gland. Remember, pituitary gland has two lobes. That's the important part here. So we have the anterior one, and what that does, it worries about growth. Am I tall enough? That's why we do height and weight. In any endocrine system, height and weight is what we're going to monitor. That was part of your assessment. And if it's not there, I'm going back to say, hey, endocrine within normal? Well, what's the height and weight? Are they normal height and weight? So it is something that measures it. Know that growth hormones is, we can be giving them treatment for this shortness. And remember, these growth hormones, it's like being, it takes a lot of compliance on the child. It is a sub-Q injection daily, just like insulin. So this child or parent has to know that we're going to be giving, in order to get that child a little bit taller, a sub-Q injection every day of the growth hormone. And then how do we know if it's working? The child grows, getting taller, right? That makes sense to me. One of the things that we have to remember is that not all children are going to grow, because remember, some of the families are very short. If the family's short, a kid's not going to be tall. You can't change genetics, okay? So diabetes insipidus has nothing to do with blood sugar. Can I say it again? Has nothing to do with the blood sugar. Diabetes insipidus is all about posterior pituitary gland. It's all about fluid. Absorbing it, keeping it, or getting rid of it too much. Either or. What do you see? In diabetes insipidus and even infants, newborns, what you see is these drink, 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 newborns crying, crying, what more, what more, what more. The funny thing is, if you give an infant a bottle of water instead of the milk, they stop crying, they're satisfied. That's what one of the first things we do to try to say, what's going on here before we make a decision. So again, stop drinking water, you're still going to urinate. Cardinal signs: polyuria, polydipsia, and everybody gets confused with diabetes mellitus because we add on hungry on there. Okay. but diabetes insipidus is only 2. Di is 2. Polyuria, polydipsia. So again, it's that, drinking a lot, urinating a lot. And what we do is we give something called vasopressin. Vasopressin can also be used with hemophilia, mild hemophilia. We mentioned it, on that week. So we give this child starts drinking, starts urinating. Well, what we do is we give a dose of vasopressin. Well, how do you know the vasopressin worked? You stop drinking, you stop urinating. Simple as that. Okay, don't overthink it. It's as simple as that. Okay, it can be given nasal, can be given IV, IM, sub-Q, all of those things. And again, there's no cure. We just have to monitor these things. Oh, and vasopressin's also used for bedwetting at night. Now, the opposite of getting rid of fluid is retention of fluid. Your pituitary gland says, nope, we're going to take all that fluid and we're going to hug it, and we're going to keep it. So now you have a child who's full of fluid. These children have, it's called the syndrome of inappropriate antidiuretic against urinating hormone. That's how you're going to remember SIADH, against urinating hormone. So what are you going to see? You're not going to urinate. And these children, what's going to be the treatment? We're going to be watching your, now I want to back up. What you're going to see is these children, we're going to do intake, output, daily weights. We're going to be monitoring them closely. Fluid, any fluid anywhere, we're going to do that. And this child's going to be on low sodium, is going to be on fluid restrictions for that. Now, diabetes mellitus, right? So this is the other one. So we have polyuria, polydipsia, but polyphagia, they're hungry. Now, how do you remember which one goes where? Well, diabetes is sugar that the pancreas can't digest, so it just sits there. So it's not used. So your body's not getting the nourishment of sugar. And your body says, I'm hungry here. Where's the sugar, right? So it starts eating fats, it starts eating proteins, and it starts releasing all of those ketones in there. So I'm hungry because I'm not getting sugar, and now I'm urinating and I'm thirsty, trying to make up, trying to figure out what's going on in my body. Now, some of the symptoms that we see on these young type 1 diabetes in pediatrics, usually it's a weight loss that a parent sees first. And then they notice they're drinking a lot and urinating a lot. And that's part of it. Now, in the adult world, they say that a hemoglobin A1C at 6 is pre-diabetic. At 6.5 would be diabetic, but we give kids a little more. We take them to 7. And blood sugar is greater than 100 in adults, but 126 in children. So it's a little bit of a difference. So remember the difference between diabetes mellitus, I need sugar, so you're going to add in polyphagia, I'm hungry, with increased urine and thirst. And diabetes insipidus has nothing to do with blood sugars, so it's increased urine and thirst.
Ms. Bogart,
Yes.
why do kids lose weight with diabetes and older people gain weight?
Not
Or is it they're just like
necessarily.
they have diabetes?
Okay,
They're not.
if you have diabetes, your body's not eating sugar. You're not getting the calories. It's not digesting. You're only getting the benefit of nutrition from fat and protein. So therefore, no sugar, they lose weight. Understand?
Okay.
So you're not getting sugar. How do you feel? You don't feel good. That's the fatigue, right? It's almost like a hypoglycemia, no sugar, but it's opposite. The sugar's in there, but you can't use it, so you feel bad. Diabetes, sometimes where you see a sudden onset enuresis or nocturia, you need to be checking for diabetes. Now, how do you check for diabetes? Hemoglobin A1C, and it will show you the last 2 to 3 months of your blood sugars. And is that hemoglobin A1C greater than 7? That means they're diabetic, right? One of the things about big babies born at birth, if anybody has ever worked around a nursery, you get a 10, 12-pound infant, you're like, ooh, and the first question is the mother diabetic? Because they feed all the sugar to the baby and the baby gains weight. And that's why you have these large babies of diabetic moms. Diabetic moms, especially those who are not really paying attention to their blood sugars and they only can take insulin. So they really have to watch it close. There was a question that I saw off of a Hesse, which talked about having an adolescent and their BMI was elevated and they're urinating a lot. So what could be that? Well, we know urinating a lot could be a lot of different things. Diabetes insipidus, that could be, diabetes mellitus. It could be urinary tract infection, right? So we will be looking for all of those things. 92% is this child is basically obese and what's going on there. So we'll be checking electrolytes. We'll be checking for urinary tract infections. We'll be checking hemoglobin A1Cs. Now, when this child comes in, this child with diabetes, brand new, or one that's had it and for some reason hasn't been taking insulin, hasn't been treating themselves right, come into, the emergency room, and they're very easy to point out. These children look pale. They're very drowsy, lethargic. Their blood sugars could be, and the highest one I've ever seen is 1,008, I think was the number, 1,000. Now, these children, what do we do? Now, we know diabetes, DKA, is hyperglycemia and with ketonuria, right? Because you have the high blood sugar because you're not eating it, and you have ketones. It's showing you your body is eating proteins and fats. So that's what DKA is. That's the definition. So signs and symptoms, that drowsiness, decreased level of consciousness, decreased skin turgor. They come in looking dehydrated. And the thing is, this fruity smell smells like a rotten peach put in a Tupperware container, put in the refrigerator for 2 months, opening it up and smelling rotten sweet. If you put them in a room, close the door, walk in, it hits you. And you're like, diabetics, immediately. It's a distinctive smell. Now, if we let this go on, body's not getting blood sugar, right? You're going to go bradycardic and you're going to go hypotensive and you will code. We've got to get this child corrected because we know not only are we have high blood sugars and we have ketones, we have an ABG, which is probably a lot lower than it should be. That child with 1,008 blood sugar had an ABG. His pH was 6.89. It should be 7.45 normal. That child did make it. That child did make it. So what happens now when we do a hyperglycemia? Our goal is fluids, bolus, like normal saline, and regular insulin IV slow continuous drip. That is your priority to start on that child. Now, sometimes we have children that are hypoglycemic, and we can tell because by the way they look. Now, sometimes it's nausea, vomiting. It does have a similarity to DKA because there's no sugar, right? Because I can't use it. So it's sort of almost the same type of symptom. Nausea, vomiting, jittery, restless, shaky, sweaty, dizzy. What can you do? Oh, give a package of sugar, give a lollipop, glass of orange juice, a honey for older kids, older than 2, That's the awake. This is the alert child. But if they go unconscious, they need to get their glucagon and turn them on the side because they will vomit right after. Now, adrenal cortical insufficiency, adrenal glands are the kidneys, right? What does adrenal glands do? They secrete cortisol and aldosterone. What is the thing with this? Well, when we talk about Cushing syndrome, it is usually that we've been taking like prednisone, a steroid, a corticosteroid. We've been taking too big of a dose and too long, and the body starts looking like this. What are you going to see? You're going to see red, ruddy cheeks, ruddy red. That's the description of it, okay? We're going to see skinny arms, skinny legs because of muscle wasting, okay? Big, fat moon face, and you might see little hairs on the chinny chin. Even acne can form, and then big type of abdomen, pendulous abdomen, because that's where it does all collect. So what do we do with Cushing syndrome? It's an over giving of this steroid. So what we need to do is to taper it off, right? If it's being given orally. And those are all your symptoms. Excessive hair growth, moon face, red ruddy cheeks, weight gain, puffy, fatty around face and trunk. Abdomen is pendulous, poor wound healing. That's steroids. And the other thing with steroids, elevated blood sugars. That was for your med surge. So Addison was not enough. So you have an adrenal gland. It's not secreting cortisol. It's not secreting aldosterone. And the whole thing with this is the assignment of sex of a child. They don't have this interutero. A baby can be born with ambiguous genitalia. I have seen a vagina and a penis. That's the one I've seen. Was it a prominent clitoris? They called it a penis. And when they looked in ultrasounds and stuff, it was very ambiguous. How do we treat these? Well, what is Addison disease? It's a lack of cortisol and aldosterone. So what do we give these children? Well, these ambiguous genitalia children will be placed on cortisol and aldosterone for life. You have to assign what sex are you going to give that child? Can you imagine a parent? Okay, so what sex are we going to make this child? And they do it based on sometimes hormones, sometimes due to ultrasounds, looking at what body parts are there, and then they assign a sex. But I've only seen one in my really long career in beads. And with these children, of course, assign the sex, monitor electrolytes, and we'll be giving whatever they're missing, the cortisol, their aldosterone. So hyperthyroidism. Hyperthyroidism is when the thyroid gives up too much hormone in the body and the body doesn't like it. So it's also called Graves' disease. And that's that pre-adolescent growth spurt, right? 12 to 14, we start to see it. Can you imagine you're not growing? There must be problems with your thyroid, or you're growing too much. Well, is there too much thyroid? These are things that we look at that age. So with hyperthyroidism, you don't have to do surgery, but if we don't, we need to do something to stop the amount of hormones secreted. So we give something called PTU, or proliprypacil. The problem with this drug, it can cause leukopenia, which means what? A decreased white blood cell count, which means these children could get fevers, sore throats, because of just being on the drug. It doesn't mean they're sick. So they should call their doctor to say, hey, I have this and that, and then they'll tell them what to do. So how do you treat when you see a child with leukopenia, with Graves' disease? That means probably too much is being given. So we're going to give glucocorticoids, which again is a cortisol, which is replacing, what they need, and it does help with that leukopenia. Another thing we can do for hyperthyroidism is those iodine procedures. We can ablation, we can do surgeries. It all depends on how irregular those thyroid hormones that are coming out, if we can control them on meds or not. Now, a thyroid storm. I actually saw she was an x-ray tech one night working in actually an adult ER. And it was her x-ray tech. And all of a sudden she didn't feel well. And what it was, she had elevated heart rate, elevated blood pressure, tightness in her chest. And all of a sudden she had a storm of thyroid. And it's, very dangerous. So they had to give her beta blockers, which slowed down the beat, and then treated the temperature, and slowly it came back around. But thyroid storms are scary. Remember, it could be from taking too much thyroid medicine also. That's why I mention it. So you have a child who's on thyroid medicine. These are the opposite thing that you might see when maybe you double dosed, right? This is what you might feel. So hypothyroidism looks just like adults, except it has to do with growth and cognition. So a child born, no stool at birth, right? For the first day or two, you say, it could be thyroid. So they do thyroid levels. And then, of course, they're going to give thyroid hormones because it has to do with their growth. And it also has to do with cognition, right? Now, as they get older, what would you see in the children? Even under good treatment, you're going to see decelerated growth. So we need to look at dosages. Dry skin, puffy eyeballs, sparse hair, constipation, sleepiness, mental decline, cold intolerance, all of these, constipation. These are some adult things, but in children, it's the mental and it's the growth, okay? So we give thyroid medicines. Well, it's to boost you up, right? Because you're tired, because you don't have enough thyroid hormone. You take a medicine in the morning. You gave it at night. This medicine gives you a little boost. And what happens is it's going to keep you awake all night long. Also with this, because dry skin, etc., increase fluids. And then because of the constipation, increase the diet of fiber. And that's a picture for you to look at. Now, vomiting. When you get an infant who comes into the doctor's office, wherever, and they say there's vomiting, especially the young ones, less than 3 months, I'm going to ask this question. Is it dribble like this, or is it across the room? And that's going to tell you basically what's going on with the child. If it's just a dribble, all right, let's go on with the assessment. It's an infant. Oh, number one, I'm going to look at that fontanelle. Is it sunken or dehydrated? Is it level? We're okay. Now, if it's sunken, I'm going to listen to that heart rate. I'm going to see an elevated heart rate. Take a blood pressure. It's going to be lower. They're going to tell me that the child has not been urinating as much. In fact, they haven't had a diaper since last evening. Slow capillary refill. And I think the saddest thing is to see an infant cry and no tears come down their cheeks. And I've seen it all the time. And it's like, oh, you poor little thing. You could tell they hurt. And then it's that skin tenting. You pull the skin and it's like, it just stays up like that. So, how do we treat vomiting? Number one, make them NPO. You got to rest that tummy. If it's to the point of dehydration, you're going to be given an IV. Now, in the IV, we start out with, that just fluids to replace it. And then we'll add in the electrolytes later on. You never, ever bolus sugar or potassium in any IV. You just don't. Adult children don't matter. No sugar bolusing, no potassium bolusing. Now, if this child's awake and alert, we gave a little bit of antiemetic. All right, let's see if they can eat. Pediatric, Gatorade, Powerade are great, great, great options. And children actually, the older children like the Gatorade or Powerade, and young children are just willing to drink anything. So, vomiting, you'll have to figure out what your baseline is and how severe this dehydration is. And that's told by that metabolic profile. So as you're starting the IV, you're going to do a metabolic profile. Let's look at those electrolytes. Start that IV, give that IV bolus of saline. Never dextrose, never potassium. And you cannot hang an IV with potassium in it until that child voids, because you're worried about kidneys being damaged. Because remember, dehydration in children is extremely dangerous. So we're not going to start an IV with potassium until they void or until we have a potassium level back. And because they're vomiting, suction at bedside and turn them on their side to prevent aspiration, that just makes sense. Now, reflux. We have older children and we have the babies. Now, the baby, that little spit up thing, they're losing calories every time they spit up. That's the biggest concern here. Okay. So, how do we keep that food down? Well, we're taught that children are not to get any food till 6 months. But in a child with GERD, this child is not is vomiting and is losing some of their calories. So we put a rice cereal. It's actually 1 teaspoon in an ounce of cereal, and that's just enough to thicken it, and it holds it down. Now, you might see rice cereal in the stool, but look at all the calories they're gaining by not vomiting, right? Another thing is not to overfeed. Let me make sure that mother knows how to burp that child good, how to sit up after they're done. Those are the things that we see with reflux. Now, infants can grow up to be children that also have reflux. I mean, we turn to be adults, and we also have reflux too. And what would you feel? It's that burning that comes up the chest and then that cough. And why do they cough? Mini aspirations. And with those mini aspirations, you're hurting the lungs. So if after every medication, every diet, everything is just not working right, these children or adults will get a Nissen fundoplication. And that's a picture. They basically fold over the stomach so that you can't vomit. As you go on in your career, look for a patient with a gastrostomy tube. 99% have a Nissen fundoplication because you want to give that feed and not regurgitate and vomit it out. Nissen fundoplication for older children. Now, pyloric stenosis. This is a condition. It's about 7 weeks, 6 weeks is a great time that I see it a lot, up to about 3 months. This is really small infants. And this is that baby who across the room is vomiting. I've actually picked up an infant and they started to vomit, and I turned, and 10 feet away was a garbage can, and I pointed the baby towards it, and the baby hit it. I go, 2 points. And I said, yep, this baby has pyloric stenosis. It actually helped the parents giggle a little bit because I look so comfortable. Can you imagine having a 7-week-old baby and, you're scared and they're vomiting like the exorcist across the room. So what do I do? How do I take care of that? Well, the first thing I do is I tell them, please do not feed your baby anymore. I already know what's going on just by that project across the room. The next thing I do is I take my hand and I put it underneath their xiphoid process, and there'll be an olive-shaped hard area, and you can feel it. It is the pyloric sphincter, which empties the stomach into the small intestines, and you can feel it. You're like, oh. Now, preoperatively, now we know they can't eat. They're hungry. They want to eat, and they can eat. There's nothing wrong with it. It's just it goes down, sits there, then all of a sudden everything is explosive. So NPO, and infants do not tolerate NPO for a long time. So we're going to start IV fluids to maintain that hydration and blood sugar. And if they have any pre-op meds, we'll be giving it. Now, liver problems, hepatitis. What you need to know about hepatitis is you need to be careful, wash your hands, proper infection control. The other thing is the teaching and how do we maintain nutrition on these children, right? These children need to have a low fat diet. And the reason is, what does the liver do? It produces bile. What does bile digest? It digests fat. If you have a liver that's not working, your fat is not being digested and you're having extreme diarrhea. Now you're losing a lot of vitamins, et cetera, et cetera. Also, your stomach blows up, it's full of gas, et cetera. So no, as little of fat in this diet as possible as we can. What they say is meat, fish, fruits, vegetables, milk, a low fat milk are really good choices for these children. So that's what you need to know about that hepatitis. Celiac disease. This is the small intestines doesn't tolerate gluten. Gluten is in wheat, rye, barley, and oats. Now, the problem with gluten, it's every toddler's dream to eat chicken nuggets and macaroni and cheese. And with celiac disease, no, because the chicken's breaded and macaroni is pasta. So there has to be another choice. You know what's great today is they really are finding all different things. Rice flour and rice is a great substitute for these children. Any dairy, meat, fruits, vegetables, they're great. If they decide to eat fat, they're going to have this, what we call steatorrhea. Steatorrhea is the fat goes in and it just comes out. It is probably the stinkiest stools you'll ever smell. It's worse than a GI bleed, and that's pretty bad. And they're bulky and they're just full of, all the fat that can't go in there. Remember, they're also losing fat vitamins. So make sure that we give them back. With food allergies, we do start feeding our infants really slow. We want to make sure that they keep their food, right? So if we're seeing an allergy, I think the greatest example here is, okay, I'm allergic to milk. All right, lactose intolerant. What does milk give the infant? Gives them vitamin D and calcium, which means let's figure out another way to give vitamin D and calcium to that child. So food allergies can dictate what you need to look at if there's something else that we need to give because they can't eat a certain food. Hirschsprung's disease. This again is another stool in the first 24 to 36 hours after birth. It is an area of the intestines that has no nerves, and it's called a megacolon. It is an intestinal obstruction because you cannot get food or liquid or anything going down through the anus and into the diaper. That area of intestines has no peristalsis. It can't squeeze it. So it sits there. Now, sometimes if you look at that little thing that just hangs down, that goes to the anus, sometimes a little bit of stool will come out and it looks like what you would take and put frosting on a cake, that little squeezer thing, like little ribbon, like little stools, okay? That might be it, or no stools. And it doesn't hurt. There's no nerves. So an infant can't tell you it hurts. So what we have to do is take out that piece of bowel. Now it's not dead. It just doesn't have nerves. So we take it out, and our goal, hopefully, is to put them end to end and do a pull through procedure. That is the optimal. Sometimes they can't connect the bottom, so they have to bring it up and do a colostomy. And usually they're going to be doing that reconnect by their potty training. Okay. But the goal would be that pull through, which means pull this one up, pull this one, cut it off, and put them together, pull through procedure. And of course, if we're doing those sort of things, you need to leave the rectum alone. It's got enough irritation in there. And because of all of that extra manipulation, they can't eat for a couple days. It's just for bowel rest.
I'm sorry, Professor. What'd you say the goal was one more time?
Our goal, if we can, is to do the pull through procedure.
Okay.
It's better than having a colostomy for parents, right? Enterobiasis found a great picture of what an anus would look if those worms were sitting there. Because it's like, is it one or is it a lot? Well, I saw pictures with lots of them there. So pinworms are children who love to go outside and play in the sandboxes in the dirt, and in them are little eggs. And if their nails aren't cut, it's going to go under their nails. And what do kids do with their hands? In the mouth. So the eggs go in the mouth, they go in the intestines, and they hatch. And now they try to come out the other end. And at night, they like to do it. And you'll see this intense perianal itching and scratching. And of course, if their butt's itching like that, they're not going to sleep, are they? So at night, we're teach the parents, get a flashlight, get a piece of scotch tape, open it up quick and get put it on the anus and collect some worms. So now we've confirmed that they are pinworms. Now, usually the whole family has to be treated. Whole family, because it's that contagious for everyone. And how would we prevent this or decrease chances? Just keeping the kids' nails short. That's it. Now, esophageal atresia, tracheoesophageal fistula. This and pyloric stenosis are always confused. Warning you, they're always confused. So, tracheoesophageal atresia and the TEF are where fluid goes in, but it goes into the lungs or it doesn't go anywhere because there's no stomach connection. Okay? Esophageal atresia, there's no connection to the stomach. Tracheoesophageal fistula is a tube that connects esophagus to the trachea. So you drink, it goes directly into the lungs. Usually, this is not seen till after birth, where the nursery nurse, oh, the blood sugar's a little low. Let me give a little sugar, water. And all of a sudden they're gagging, coughing, choking, turning blue. That is the hint that this is the child with tracheoesophageal fistula or esophageal atresia. So the problem with this is we have to reconnect it or take the fistula away. Every time they drink, it goes into their lungs. So even if they swallow their own saliva, it can go into their lungs. So our biggest worry here is mini lung aspirations. It's their own saliva that they're putting in. So treatment. Well, we're trying to decrease the amount of aspiration that's going on here. So how do we do it? Well, we're going to keep the head of the bed elevated. We need suction at the bedside. Yes, this child is not going to be fed until this is all repaired. In fact, many of them get a G tube in preparation to give them get bigger before they'll do that treatment. And then, of course, IV fluids, initially maintaining fluids. And TEFs get antibiotics, not pyloric stenosis. Why does TEF get antibiotics? It's because they have mini aspirations. So you're preventing infections from those mini aspirations. And this is a child that's not going to be eating by mouth. So we need to take care of that oral thing that they have. Make sure they have a pacifier. This child needs that suck. How do they soothe themselves? How do they comfort themselves? It has to be, with their mouth. Appendix, we talk about the one that has burst. The one that has burst has spewed all of this toxic material inside the abdomen. And with that being said, we need to know how to take care of this child post-operatively, right? And pre-operatively. So the kid comes in that right lower quadrant, McBurney point, rebound tenderness, the whole thing, do an ultrasound. And yes, it's an appendix. The child will be made NPO, given IV fluids. And of course, it's an infection. We're getting antibiotics. And then if there's any pre-op meds the kid gets, if they're on, they can get most of them. Now, by the time you got it upstairs to the OR, this child has already perforated the appendix. So now you have a post-op peritonitis child. And what is it going to look like? And what are you monitoring? Well, that whole peritoneal cavity had all this toxic material spewed in there. The intestines are angry, so nothing to eat or drink. They are not moving. There's no peristalsis going on. They've shut down because they're angry. Nothing to eat, IV fluids, antibiotics. Now, one thing we'll be monitoring is their lab values. Well, I want to know, is the white count coming down, right? Are my electrolytes okay? We're going to be NPO, make sure that we get potassium. Also, we're getting an NG tube. And why do I have an NG tube? Well, all of that gastric acid goes into the stomach intestines, creates irritation, and it hurts the tummy. So NG tube, keep that stomach empty. And of course, you got to monitor that drainage. If it's too much, again, they're going to be losing electrolytes. That's why we're monitoring lab values. Now, the other thing that we forget is that abdomen was completely, unsterile now. It's contaminated. And we closed up that incision with 2 contaminated edges. The possibility of dehisce is huge. So assess the wound. I've seen one dehisce on me. So it's because it was the dirty to dirty, and they sewed it up. So again, assess the wound. Make sure that we work on their pulmonary care. Kids can blow bubbles. They can have a pinwheel. I used to do on older kids. Well, I worked night shift, so I would do spitballs. I would go get some straws from the cafeteria, take a little bit of paper, and I said, oh, make a big target. And the adolescent kids, let's see who's going to win tonight. And 3 o'clock in the morning, the kid's awake. I'm doing pulmonary care. And even the doctors used to say, wow, this kid's lungs looks better than yesterday. And they would say, oh, Betty was on last night. So they knew what I was doing. Of course, up and ambulating, get those intestines start to work again, making them start to pass gas. Omphalocele, bladder exstrophy, gastroschisis, anything with the body born on the outside that should be on the inside. That's what this is. I finally found a picture of what the tent looks like when they stick this thing up in a tent to try to push it in. And they have it hanging off an IV pole, hanging it up so that by natural, that the intestines could slowly go back into the abdominal cavity because there's no space. We have to stretch it and make space. It was born like this. We got to open it up, okay? So omphalocele, all of those are nursing care, and they're all the same. Body on the inside should be there, but it's not. So at birth, at bedside, sterile, normal saline, in a sterile dressing. You got to make sure that you protect that skin integrity so we can close it up when we're ready to do it. And it's not because the skin is not good that you can't close it. So protecting skin integrity, very important. They're not going to be in a crib or anything. They're not going to be all swaddled up. We need to monitor that abdomen or that back or whatever it is. And we're going to be putting them in a warmer with heat. And remember, their insides are on the outside. So we got to protect from infection. We're going to do prophylactic or preventative antibiotics. Child's not going to eat till we get it all fixed up. And of course, IV fluids will be given, for fluids. Now, Meckel's diverticulum, small intestine, a little skin tab is in there. And inside those the lumen of the small intestines is the skin tab, and it has a big blood vessel in it, and it tears. So it just dribbles blood through the GI tract. It doesn't really hurt. I mean, it says it might have a little bit of tenderness, but what you see is painless rectal bleeding. They go in, they do this special x-ray test, they do surgery, and these kids are fine. Now, nephrotic syndrome. This is not renal failure. Let me tell you again. nephrotic syndrome is not renal failure. What it is the kidneys say, protein, I don't like you, and they get rid of it in the urine. So all your protein in the body is being lost in your urine. Well, what else is protein? It's in your blood system. That's also called albumin. And we know albumin and drugs, we need a certain amount to give them so we don't get toxic. So this is a big deal, renal failure, just giving meds. So what do you see? All the protein's going away. Where does it come from? Massive proteinuria in your urine. Hyperlipidemia has to do with your cholesterol also. And then hypoalbuminemia is all the protein in the blood is gone. What happens because of that albumin gone, there becomes a shift in osmotic pressure. So the inside becomes more like a hypotonic and it starts spewing fluid interstitially. And these kids get overwhelming generalized edema. So they're retaining fluid here. Do you see that? So fluid, child, what do? Intake, output, daily weight, right? Also, it's fluid restriction, just like SIADH, right? It's going to be salt restriction, fluid restriction. So nephrotic syndrome is, they are immunosuppressed, so you've got to be careful with them, washing your hands, but it's not a cure. Acute glomerulonephritis. This is a curable disease. Acute means it happens. Chronic means I'll have it forever. It happens because of a strep infection not treated. So what is the treatment? Long-term antibiotics to treat the strep. Now, glomerulonephritis, what do you see? Well, it's the kidneys stop urinating. You stop urinating, you retain fluid. You're retaining fluid, you become hypertensive. And acute glomerulonephritis has periorbital edema. With that elevated blood pressures, you're going to have headaches. They're going to be severe. So what are you going to do? You're going to monitor the blood pressure. You're going to see protein and blood in your urine, and those things are normal that we see. And as long as we treat it, it'll all go away. So again, it's a fluid balance issue. They're not urinating. Daily weights, intake, output, and they also have this child just measuring abdominal girth measurements, and that would be on your younger kids to see if there's fluid building up there. Of course, low sodium, fluid restriction, and as I said, they're immunosuppressed, the susceptibility to infections. Now, renal biopsy is very close to a cardiac cath. What this is you have a child that either has a tumor or has resistant urinary tract infections. They need some tissues from your kidney to figure out how to treat the child. So it's basically NPO before the procedure. Infants, you're not going to have as long that NPO, but basically NPO and, trying to get that child to understand they're going in for this procedure and what to expect post-operatively. Most of the time they are medicated for this, sedated pretty good. So as a nurse, you get this child back from a renal biopsy. Of course, the first thing I always check, just like cardiac cath, I'm going to check the dressing on the back where that kidney is, because the kidneys are in your back. And just like cardiac cath looking for blood, I'm looking for urine or blood there. And it's the same thing, pressure dressing and maybe a sandbag if they can. And because we don't want any of those clots to dislodge, bed rest for 24 hours. And of course, you stuck a kidney. You want to measure intake and output and making sure that none of this fluid or blood is going into the abdomen. You would see abdominal pain or tenderness if that happened. So if you start seeing abdominal pain, tenderness, most likely something's oozing from that biopsy. Infants, because they're so small, might have a tiny little incision line, okay? And we find the kidneys with an ultrasound probe at the same time. Renal failure, the kidneys don't work. It could be acute, could be chronic. Know that with renal failure, our goals are fluid electrolyte balance. And of course, this is the one where the kidneys aren't producing their erythropoietin, so we can give sub-Q erythropoietin for these children. And, you know, I say it on every kid, any diagnosis, promote a normal and as active life as they possibly can, as in let a kid be a kid. Now, peritoneal dialysis is a new option. They're using it more and more than I've ever seen before. Actually, I had a best friend who was a nurse with me who ended up on peritoneal dialysis, and she used it for many years before she couldn't. But peritoneal dialysis in infant is the only way we can do dialysis. You cannot put them on a machine because the turbulence of the flow will make their heads explode and you'll have intraventricular hemorrhages in the brain. Okay. So what we do is we stick a tube into the peritoneal cavity and we put warm solution in there. And then we let it sit inside the tummy for a little bit and sucks out all the debris. And then we drain it into a Foley bag. Now, what is your job during all of this? Now, our goal is to keep that sterile. I mean, this is, you put a hat on, gloves on, gown on, everything for these children because this is the only kidney they have. There's no other choice. So we're watching for any redness, tenderness, and that fluid color change is a big thing. If you see a change in the color of fluid, it's probably something going on, maybe, maybe not, but tell the doctor, and we're going to get that child on antibiotics right away. As in, this is a better safe than sorry. Scoliosis, S-shaped curvature. A really good nursing diagnosis is a disturbed body image. They have one shoulder up, one hip up, and these children are very self-conscious about the way that they do look. Remember, they need 23 hours in a brace, 1 hour off, put a cotton t-shirt underneath it, no powder, no lotion, no oil, any of those things. And then they get really, really good physical therapy and they strengthen the core muscles and it will straighten up on these children. The thing about scoliosis is bigger than 45 degrees, you need surgery, which isn't that bad. It's like almost halfway up, right? But look what happens to the lungs, how it pushes them in there on that picture. It's like squishes them. So if it's above 45, they really need to straighten it because the lungs need to be able to breathe. DDH, developmental dysplasia of the hip. The little infant who's born and the hip, the femur head is not into the hip socket. It's usually up here somewhere. So what do you see in these children? Well, that leg on the side where the hip is not where it should be, it's going to be short because it's up here. It's not here. You're going to see abduction of the hip on the side. Also, the gluteal folds, that means the buttocks. The one with the hip is going to be up here and it's going to be down here. So they're going to be unequal. What you're going to see, you're going to pull, you know, the pediatrician moves the legs around here, clicking. It's going to be a positive Ortolani and a positive Barlow test. So what do we do for these children? They don't need surgery. These children, bones are soft, healing 2 to 3 weeks is what my lecture was last night. So the quicker we get this Pavlik harness on, the quicker we can get that hip socket back where it needs to be. So the Pavlik harness is for abduction of the hip. I say ab for Bogart, abduction of the hip. We want it put where it needs to be. Again, 23 hours a day, soft t-shirts underneath. These children, please monitor for skin breakdown and massage the areas underneath because they are moving and they do get a little red. So make sure that they're massaged really, really well. Now, the top picture is also developmental dysplasia of the hip, but that's Bryant's traction. The thing with Bryant's traction is there's a traction that goes up with a rope and then a weight that will hold them that way. This child has to be less than 30 pounds. The angle is a right angle. and their buttocks are a little bit off the bed. And that sort of holds and tries to get that hip back to where it needs to be. And that's Bryant's. So types of fractures, simple as a normal one. They fall down, they broke their arm, they come in, they get a cast. It's, 4 to 6 weeks, the cast comes off. Now, they fall down and now they've really done it good. And now their bone's sticking out of their arm. There is an open abrasion, laceration, and you can see the bone. Well, you have now allowed the atmosphere to enter the body. So we know number one is antibiotics. Prevent infection, prevent osteomyelitis. Check neurovascular signs, right? We have complicated comminuted, which has to do with bone fragments in there. And then there's avulsion. It's what the bone and the tendon sort of rips away, which is a serious type of fracture that sometimes that needs surgery for it. And then, of course, child abuse is that taking the arm and pulling it and twisting. And you see a twist fracture, it's usually child abuse. So again, those types of traction, we have Bucks, we have Russells. They're about the same thing. Russells just has that extra piece there. Your job in traction is to make sure those weights are hanging freely and you never take them off. And you document what the weights are at the beginning of your shift. As I said, the Bryant's is congenital hips. The hips are up a little bit, legs are at a right angle. And again, it's that 30-pound weight. Teaching yourself, teaching the child, teaching the parents, what are all the 6 Ps, especially right after you put that cast on that child. It can go compartmental syndrome for too much pressure and swelling going on. So it's something that really needs to be looked at. So pain, pallor, pulselessness, paresthesia, paralysis, pressure. Those are things you're going to monitor. Now, these casts, children want to stick pencils and hangers and all sorts of things in them. They do itch. The thing is, nothing inside of them. The only thing they say for itching is a cool hair dryer. The thing is to keep the cast dry. Now we send them home with bags for short arm, short leg, long leg. Yes, doesn't mean they use it. And it doesn't mean, like I had one little boy, I've told my class, I think 7 or 8, I don't even remember his age, but young. And he got his arm cast, went home, put his bathing suit on, and jumped in the pool. So the mother turned around and brought him right back in. And then he did it one more time. And we told him that we wouldn't have him one more time. But it does happen. Kids, I love kids. Cerebral palsy, what is it? Well, definition. Impaired muscle movement, hypertonicity, poor posture, causing activity limitations. Now, muscles don't work the way they want them to, okay? They're hyperspastic. They tend to be twitching. They're so tight, okay? So one of the things with cerebral palsy children is things like, how do you feed them? We think about the walking and ambulation and hands, but what about the muscles of the mouth and eating, right? Again, taking extra time, elevating the head of the bed, having suction around, monitor for aspiration. And again, they need time to help their muscles chew. Remember, their muscles don't work the way that they want. It does not mean they can't eat orally. It just takes a lot of extra time. So children with cerebral palsy, they do need extra things to help them. I've seen children with cerebral palsy used to not be treated and just do maintenance care. When I was an 18-year-old kid doing working for the Cerebral Palsy Center, and I used to volunteer, we only did custodial type care. What I see today, and what really is amazing, you could take a child that looks like they don't know what's going on or aware of their surroundings, give them ability to communicate, and you find out they're actually very awake, but they're nonverbal. Some of them, they can't talk. So physical therapy, speech therapy, occupational therapy started as soon as we suspected will help those children catch up and go be more than you ever thought they could be. Remember, cerebral palsy, many of them are epileptic, so dental hygiene, because the medications they're on, the phenytoin, the dilantin, gingival hyperplasia, remember that from pharmacology? So yes, good dental care, giving the meds as they need. Always safety, safety, safety. You know, you're talking cerebral palsy, autistic Downs. Safety is always your number one concern with all of them. Again, with the feeding, you're going to be preventing that choking, protecting from fall risks, and then have them busy, have them doing things, you know, sitting in front of screens and clapping hands. If you're happy, if you know, clap your hands. And you'll see these kids with cerebral palsy trying to do it, and they're nonverbal, and you're like, oh, okay, look at that. And it just warms my heart. Remember, these children go home to parents. So again, support parents. Now, you've got dosage calc. I've given you all your sheet for your MedSurg 3. Here's recordings if you don't know what's going on. And they're there. If you need extra help, I'll help you. You've got your Kahoots. You've got everything you need. And I wish you guys all the best.
Hey,
Thank you so
Professor,
much.
I just wanted to
Good
tell
day.
you, last exam was like, thank you.
You're welcome.
Thank you, thank you.